Hey guys, welcome to Smart PT. My name is Jonathan Reimer. Today I'm going to talk about first rib dysfunction, how to spot it in your subjective and objective examination, and what to do about it. So subjectively, the patient will often come in reporting either a traumatic history, tends to be a lateral whiplash type of mechanism, is very common, but also can be in a more insidious onset. It can be due to postural factors at the desk and just progressive tightness in the scalenus muscles. As you can see in the anatomy slides, the first rib is a point of attachment for the scalenus anterior and medius. So tension in those muscles due to postural dysfunction can pull up on the first rib. They often spasm after trauma as well. So fixating that first rib in a superior direction is most typical. First rib dysfunction can also cause pain in the upper trapezius region, at the cervical thoracic region due to the joint dysfunction. It sometimes mimics rotator cuff pain, and it also can present with pain in the sternocostal region underneath the sternoclavicular joint. I also will sometimes see a thoracic outlet syndrome type presentation with vague neurological dysfunction in the arm. This is because the first rib is the base and the scalenus anterior and medius are the walls of the scalene triangle where the brachial plexus is exiting. So sometimes an elevated first rib and spasm in those muscles will close the sides of those walls on the brachial plexus. Objectively, what do I see? I tend to look at positional testing. I'll sometimes see that the first rib is sitting in an elevated position, so it looks like the upper trapezius is sitting high on that side. And then I proceed with osteokinematic testing. I'm looking for a posterior rotation and inferior glide on inspiration. So sometimes the rib will be fixated and you almost will see a reverse motion because T1 does extend a little bit with inspiration, but the rib is sitting fixated. Then I'll move on to passive accessory motion testing, and I'll generally see a loss in the inferior glide posterior rotation at that joint. So then what do we do for treatment? As a manual therapist, we will incorporate some mobilizations. I'll either gap or do an inferior posterior medial glide of the first rib. I'll have to work on T1-2 mobility as well generally. I follow that up with stretching. I like a towel stretch across the first rib with a side flexion to target the scalenus anterior and medius a little bit more than the upper trapezius. There's another stretch that I like, and it's basically a combination of kneeling at the bedside, bringing the arm, if it was a right first rib, I would bring the right arm across and the left arm through, and then I would drop the chest towards the floor, and I'll couple that with inspiration in that position. I also like to work on postural correction. I think that's an important part of the puzzle for most problems, including the first rib. If you want to check out our courses, this is exactly the kind of things that I show you how to identify and show you how to treat, including the manipulative techniques for treating this problem. All right, have a great day.